Hello everyone, this is Sadhana Alangar, HL7's Director of Education. Welcome to this discussion on accelerating FHIR adoption for payers. Our panelists bring vast experience in healthcare to this discussion. Amit Shah is the Senior Director for Shared Applications and Services at Guidewell. He has over 20 years of experience in IT and health IT. Greg Barnowski is the Senior Director of Front Office Solutions at Independent Blue Cross and has over 20 years of enterprise architecture and solution development expertise. Jeffrey Springer is the Senior Vice President of Healthcare Solutions at CTS Tech and has over 20 years of expertise in healthcare. Eric Schulz is the Executive Vice President at CTS Tech, former CEO of Harvard Pilgrim Healthcare and Fallon Community Health Plans. At this time, I'm going to hand over the program to Eric Schulz. Hi, Eric.
Hello, Sadhana, and thanks for the introductions. And also a special thanks to HL7 and you and your team, and to our friends at CTS Tech for making this webinar available today, and especially to our panelists. And I'm going to start with some questions in a moment, but just a couple of opening comments if I can. And thanks everyone for joining us here today. As a CEO of a health plan, and that was for about 18 years, 2 different health plans, I was always frustrated by how much capital we had to put into technology. And the pace of capital investments over the last 2 decades has just catapulted. The other thing I would say, and we were chatting earlier as a group of us, the moderators, the last thing anyone wants to hear, and certainly the CEO, is that we have a FHIR in the house. So once we started learning about FHIR, and this is frankly is a new acronym among so many of the managers in health plans today, it really has taken on its own life. Lots of questions, lots of learning. This is a good example for us to share what others are doing. So, clearly CMS has taken the stance that they're going to place regulations on the payer industry as a means of implementing a number of things that ultimately makes interoperability work in the United States. It's been a long time coming. The rules that they've placed on you all that need to be implemented for next year are significant. Now, I will tell you that as I chat with health plan executives across the country, at first I was hearing more conversation around, well, what do we need to do to get this regulation implemented? But more and more, and this is really the way to go, and the way I would approach it is, let's satisfy the requirements, but concurrently with this investment of time and money in change, how can we use these changes in a way that benefit our health plan, that better position us against our competitors, that give us a better set of tools to better engage members, or to bring value add to the providers that we need to be, or frankly, to create a set of capabilities that pushes off the constant drumbeat from those that are trying to disintermediate the health insurance industry. So the good news is there is more and more interest in making this a strategic move rather than just satisfying one more set of regs from the federal government. So here today, we've got a few questions to get this going. I'll ask the questions, the panelists will respond, and then we want to leave the last 15 minutes or so for questions from each of you. You all have the ability to write some in. We'll do our best to get to all of them, or certainly most of them. So thank you to all of our panelists, and let's begin. I'm going to throw out this first question that will come up. It's on the screen. The pandemic certainly has impacted all of us, our families, our friends, our lives, but in the workplace, there's no question. And even as it pertains to data exchange. Jeff, how do you see the pandemic impacting data exchange and efforts around that today?
Yeah, so first of all, thanks, Eric, and I'm sure we'll get to Amit and Greg around this to get health plan specific views, but I'll give more of the industry views. We talked to a number of different players around this. So the pandemic, first instantaneous reaction from many of our customers is we need information. So who are the patients, the members who are getting sick, who have tested? Do we have enough beds? Do we have enough PPE? Do we have the right estimation of what's going to happen around this? And voila, new interfaces need to get built for analytic purpose, for data exchange between entities, between government, and it's the same way all the other initiatives that I've been a part of have been built. It's point to point, it's custom. How do we build towards that? And so as we think about payers in general, or even providers in general, they're not one organization, they're a multitude of organizations. So payers have care managers, utilization, risk, quality, stars, so on and so forth. And they all need information from both clinical and financial systems. But as we look at the way this data is typically exchanged, it's all custom formats. So the government's tried over a number of different times by bringing standards in, whether it's things like Blue Button or going to CCDAs or HL7 standards. But really, healthcare standards are things that are not really standard out there. And so as we enter new eras of how business is done with CINs, ACOs, where data exchange becomes more and more important, things are at risk, the ability to share across these systems becomes more important. So if you're building point-to-point interfaces, you're going to do it just for the data that you need, and you're going to end up with a less than robust view of everything that's out there. And what you really need is a way to cut that cost and to share it more easily. As Eric, you pointed out, the frustration of needing to rebuild all of these interfaces every time you have a new initiative, a new need, is incredibly expensive, not just for the first time you build it, but then the ongoing maintenance of it. And so what you really need is a systematic way across not just the enterprise, but the community at large to be able to share these things seamlessly. Just one small story from COVID. I was talking to some providers about patients as they came in and that were intubated, and they said that they went to the HIEs that were out there to try to get some information about the patients because the patient couldn't talk. They weren't able to give information. The HIEs were helpful, but it still wasn't holistic. And so as we look at the data exchange needs of the future, being able to seamlessly share this, not having to custom build every time becomes the real answer. And so you don't have multitude of point-to-point systems. You have a ubiquitous way that you can share. And there are some initiatives that have been out there. HIEs are one, but a lot of the EMRs have created information islands where they can share information across their EMRs. But the government really has stepped in here to say, let's create a universal way to share this data, which I think is a great step towards the future.
Yep, long overdue. Comments from Amit or Greg?
Yeah, one of the things that I think, Jeff, you mentioned is very, very clear that with COVID and with pandemic, there is a lot of disruption that has happened across personal life, overall all industries. But specifically healthcare, it's brought up some very intriguing questions. A provider who is a primary care wants to know, where is his patients? Is any of them recently visited an ER or gotten the virus that they should be following up with them? On the other hand, the patient is thinking, I just gave my test, but I don't have my results. I'll have to call and find out. Why can't I just get it on my smartphone? It really begs the question of how isolated our entire healthcare system is. It's not in an ecosystem where everything is talking to everything else. There are a lot of issues that are basically coming up as a result of that, and several of these committees that are at the national level. You mentioned not point to point, but multiple different ways in which one entity can talk to a lot more entities. That's where we need those national highways, and we need those roadways that can help connect all of us. And one of the things in that connection is also around ability to identify member uniquely across all over the place. The member of a payer's insurance company is the member, or a patient to a provider's office is the same patient that is gone to an EMR or another hospital. It's the same entity, but we don't have a way to have a unique identifier for that. And there's a lot of controversials around, whether we should have a unique identifier for a member or not in the industry. But if something like that is there, it would definitely help solve some problems. And just like that, there are a lot of different questions that beg that, what and how we can address it to create a proper ecosystem that helps connect everything together.
Yeah, I agree.
Yeah,
please, Greg.
I'd like to echo one thing, and I think this is in line to what Jeff and Matt had said. Getting the data in the hands of the patient is critical in my mind, because if the patient has access to their data, right, it sort of helps with some of the challenges that we as payers and providers have with identifying the uniqueness of an individual. If the individual has that data and is able to be the center of their own universe, so to speak, and they have the data across multiple endpoints of which they're being serviced, and they can serve that ubiquitously to another endpoint in a secure fashion, that sort of helps us all. And some of the challenges that we have with trying to do that as a central hub kind of model. So I think this data exchange and some of the things that are changing are really a big step forward for us to be able to get to a point where the patient is the center of the universe and owns that model of their data and how they're going to exchange it. So it's all good stuff. It still doesn't derail us or make anything easier on our side, but it's still, in my opinion, is a big step forward for the individual themselves to be having access to that information as they need it.
Yeah.
Yeah, I would agree with what Greg said here, but as an industry, I think we've really prevented the member from easily getting to their data. So the data has been siloed. So how do I get a view of everything that I should be doing as a member, a patient, a person, and what are the results from multiple providers that I've had? So if I go to two providers that are up the street from each other, I can't get a single view across those. And there have been a number of vendors, even the biggest companies in the country, like the Apples and the Microsofts of the world, who've tried to create a patient view of this and have failed because the access to that data is just not there and is almost impossible to get. So 100% agree with where, Greg, you were going with this. And I think this gives us a unique opportunity as an industry to really innovate about getting that data to the member, because it's possible with this approach for the first time.
Yeah, and when this does happen, I will tell you that members, the value add for members, once they have the power of the information in their hands, will be pretty remarkable and very strategically important to the industry, without question. So let's move on to the second question. It's kind of related here. We're all considering lots of things relative to each individual FHIR strategy. How does it align with the overall company vision? Do we focus first on just complying to what the regs are, or do we adopt FHIR as a foundational component of a much broader strategy? Greg, let me throw this one to you first, if you would.
I think this is such a great question because, the availability of sharing data, especially like health data between what I call the 3 Ps, the patient, the provider, and the payer, we in Independence, we've supported and championed that capability for a number of years now. We started very early on with supporting our HIE. We mentioned HIEs early on, and we've supported a concept of health share exchange. And we had other efforts in-house called our Facilitated Health Network and support for Blue Button 1.0 and other things. So from an Independence perspective, we were really adopting as fast as we could and early on to the emerging FHIR standards. And one of the first things we did was very early on, we actually implemented a production version of DSTU2 in production for some of our health and wellness software member portal. So the FHIR initiative really aligns to those items that we believe are technology enablers to our vision. And that vision is really a mission to our membership in support of their health and wellness. So to that end, we've taken the approach to leverage our key technology partners and continue on our FHIR journey and building to meet that CMS compliance and meet those deadlines. Our approach is to use a mix of internal vendor partners and expertise. And our CIO, Mike Venera, has really taken the additional step and said, hey, I'm challenging you technology folks to go beyond just the CHIP and the Medicare mandates and really create a solution that will support our membership across the board. So the FHIR capability is really a key to our API strategy. It is a key enabler for where we want to go, and it's part of our technology roadmap for our front office. So we really do see this as an opportunity going forward as part of our vision and mission and strategy.
Yeah. Any other comments?
Again, I think very, very closely aligned to what Greg said. The key is you cannot look at this as just one mandate. You have to kind of look at it at an overarching way. This has to almost become a strategy for any organization. And I like to compare this with about a decade or so ago, if you were to look at the finance industry, they did not have any ways in which, today it's the norm to deposit checks over your phone. It's a norm to, transfer funds over your cell phone. All that changed over a time. It all happened because of, proper security and APIs in place. That's exactly where healthcare is going right now. And so if you look at it with one mandate at a time versus look at a holistic picture, it has to be that you have to look at a full-fledged strategy and kind of plan it out that way. So one of the things we are doing at GuideWell is kind of looking at it from a member point of view, what is it that we need, from a provider point of view, and how we can build the right connectivities for them. And just from a payer point of view, what are the things that we can do to make our day-to-day improve? So all these three are very critical. And so overarching strategy is going to be the key, I would say, for any organization.
Yeah, and just one more comment, just to build on what Amit said. I love the analogy to banking because it's similar and different at the same time. Totally agree that the other industries have created this standardization. But when you look at healthcare, you've got 300, 400 payers, you've got 3,000 IDNs, you've got 6 million individual provider groups that are all their own individual businesses. And so they're optimizing locally for what they're doing. So you really needed the government to step in and create these standards. Otherwise, those individual provider groups, there's no chance that they're going to spend their technology dollars, which are not very high. Eric, you talked about payers having high IT budgets. For the providers, they're just trying to make their margins meet. And so they're not spending that money. The government coming in and forcing the EMRs to comply with that then enables that industry view that Amit was talking about and to create that standardization out there. And so looking at it from a strategic perspective, we're starting to see payers align with their providers on these standards and forcing the vendors to all comply to a single standard. So I'm very hopeful that the strategies that both Amit and Greg are talking about from the strategic level can actually be achieved this time, whereas before you ended up with blockers in the industry who were trying to create their own little fiefdoms and protect their data because it was their business strategy as a separate entity.
Yeah, I'm glad to hear that, Jeff. So let's move on to the next question. The analogy to the finance industry is one we often use and hear. And let's face it, financial information that we all have for individuals is very private. But we also know that within the healthcare arena, the kinds of information that we're dealing with is ultra sensitive. And it brings into light the need to have proper consent management. So the question here is, how are payers prioritizing member experience? We want a better experience supporting the provider, better provider engagement, and also thinking about and building the right type of consent management. Amit, can I throw this one to you first?
Sure. No, this is a very, very critical question. In these times, as we are changing the way in which we have been used to, getting the information and interacting, it's changing completely. And so the most important thing for our patients and members is that they get as much as possible all the transparency and the data that essentially belongs to them. And because of that, this mandate is really critical in making that happen. So it's when we talk about making data available and making it transparent, there comes the question of security. So as much as we want to do that, we want to ensure that security is in the forefront. And that's one of the ways in which we are approaching it at GuideWell. So a member can come through any particular app. They can download and utilize that to get information on the last doctor's visit they had, or whatever information that the payer has on them. The key is how do that third app talk to the payer's application, so we can ensure that it is truly the same member that the payer has is the same patient that went to that provider's office. Again, it goes back to the question I brought up earlier, which is around a unique member ID, which we don't have nationally. So where this becomes really critical is doing a proper matching of information, so we can uniquely identify the member is the patient. And there are several ways to do that. As a member basically registers in the app, the mechanism we are utilizing is they would put in their information and also provide information about their payer ID or what have you. When that app then connects to the payer side, using OAuth, which is a mechanism that really helps us in a secure way authenticate. And in that mechanism, we essentially validate all 10, 15 parameters that we are looking on every single individual. And every single of those parameters have to essentially match for us to say, yes, this is the same member that is the patient coming in. So we are taking a lot of effort in ensuring that. We traditionally did not have tools in place to do that. We've actually installed and configured new tools that can help us better manage this and have visibility and tracking on how this interaction is happening and how the authentication is happening. And then once this authentication happens, then whatever information that the payer has, we then send that over to the third-party app. So it's a change, again, just like anything else, for the member to receive information like this. But again, with the analogy of finance, it's just like going to Mint and getting your information. It's kind of like that. But at the same time, it's also a big change for payer. We are not used to sending such information, and so we are taking all kinds of precautions and ensuring that at no point there is going to be a breach in any way. And so that's really the focal for any payer organizations. And I'm sure the members are also looking at it from their point of view on what is the measures that this security measures that these third-party apps and payers like us are doing, to ensure that their information stays secure.
Yeah. Thank you. Greg or Jeff, anything to add to this?
Well, I'll just jump in, and I sort of agree with Amit. I mean, there's two things that we have in play here. One is, making sure we have a really ease of use for our member experience, and sans any overarching CMS regs to support how we govern the consent management. We have to make sure that we have to do two objectives: ease of access and security. And this is where Amit was coming from. So making sure that those two objectives are in play on our side, we've already started to engage our MX team. We have a member experience team. We've engaged our operations team, so that when we're thinking about how to make life easy for a member to come in and get access and allow a vendor to have access to their personal health information, it's not just a single channel, it's a multi-channel. They can do it for a call center, for example, and they can do it for online web environment, right? We've also engaged our legal and compliance teams for appropriate reviews and creations of the terms and conditions and how we're going to manage the security of that data exchange between the member and independents and third party. And I love what Amit said. Payers are not used to having exposure of member PHI information to what we call an unknown party per se. It's a party that could just come in and request it. We don't necessarily have a relationship with that party, but the member is now driving that relationship for us versus us driving the relationship with the vendor on behalf of the member. So again, it's a fundamental change. And then we had the third thing we have to do is create that technology approach to support that consent that adheres to what the MX team's saying and the compliance teams are saying. So we get some of these challenges, like I just said, how long does a member consent stay in effect? What are the mechanisms to be in place to renew or cancel a consent for a member, so that it's done in real time? And what are the limits should we impose on a member? Can a member have their data shared between more than one vendor? Can they have it shared to many vendors? And what are the other channels that we should consider? Like we've talked about call center and the ability to self-serve off our IBX portals, right? But what about email or being able to send in a piece of paper? All those things come into play when we're thinking about that consent management, the member experience, and then layering in to make sure that we have that deep security. Because I think, Amit, I couldn't add much more to what you said. It's all those things and above.
Yep. So 100% agree with Amit and Greg where they went with this on consent at the member level. Let me just spend a minute talking at the provider level, because this becomes interesting as well with what some of our customers are looking at from that perspective. And when they look at internally, they see 2, 3, 5 groups doing outreach to providers for the same conversations and using a number of different systems to manage that. So whether you're talking about the risk group, the claims group, utilization, quality, all doing outreach to providers. And what they're seeing as you start to create a centralized data strategy around this is the opportunity to streamline that communication and really not just think about it from a data strategy perspective, but a business strategy perspective, not combining those groups together, but centralizing the outreach so that you're doing it once, leveraging that information across the different groups. And so we're starting to see more strategic type thinking around that of how does this data strategy change can be leveraged to create business efficiencies as well.
So Jeff, you're bringing this point up, a good point on the provider side. But when you think about it, the provider industry has their own language and what they call data. We as a payer industry have our own language. What's happening to create some sort of, how do you connect? It seems like, as somebody wrote here,
Yep.
a large mapping exercise. I mean, how does it happen?
Yep. Yeah, so I would actually just point back to what Amit said, and I lost Amit's picture, so I'm not sure if he's still here to reiterate, but he's talking about patient member matching, which becomes incredibly important. How do we make sure this patient ID from the payer side matches to this MRN? And it might be multiple MRNs because that patient has gone to multiple provider systems. So here's a view, a centralized view of that patient, that member for the providers. They're using it today from HIEs, and it's really not complete. This enables us to create a complete view, and that patient matching that Amit was talking about becomes central to creating the same view of that patient, that member, both payer and provider. As we get to more and more risk-based contracts, this doesn't become a nice to have, this becomes a must-have, because as you're managing those members and the risk around them and the providers are doing the same, if you don't have that same view, you're going to end up with a equally as contentious relationship around, oh, that's not my patient, that's not my management of that. And so this question becomes incredibly important.
Yeah, thank you. Well, let's go on to the next.
Can you hear me? I just, for some reason, my video is not working. But Jeff, to just add on to what you just said, provider in getting information on the provider is more like I call it from the back end for a payer organization. This is critical information to share. At the same time, the front end, which is the member information that we are talking about. So there is 2 different aspects here. and the provider-related engagement in exchanging the information with the provider and getting that is a whole nother ball game, and how that occurs is there are several different EMRs in the industry, and how do you get information as much as possible for all the members that are catered by a specific payer. So that has a whole nother level of security needs, a whole nother level of ability to have the right engagement model, and how that information exchange would work.
Thanks, Amit. We've got some questions coming in. Let's go to the last question here, and then we'll turn to these other questions as they come in. And this is probably a good one to kind of wrap up things from the panelists. When you think of FHIR, what's the impact on your data management strategy? And what are the challenges that we're all facing with the implementation of this? We touched on some of this, but let's kind of wrap it up. Greg, you want to go first?
Sure. So yeah, this is actually another great question, because the impact of what the CMS interoperability is going to do is it's going to change in some fundamental way how we want to expose our information and how we're doing it today. So within IBC, we've had a master data strategy in place for a number of years, and it's really been centered around our corporate data warehouse. And included in that strategy was this concept of exposing that master data in areas such as our member and our provider data and our claims, our clinical data, financial data. There's like 7 or 8 master subject areas that we consider when we're putting that available out into an operational data store. So those architected operational data stores have been over the years wrapped with our own internal services, our own web services, and exposed to portals and other various means, and used in various ways to share data, but not only for our portals, but also between our HealthShare exchange, our federated health networks, and things like that. So what's happening with the new FHIR impact on our data managed strategy, it's really doing one of 2 things. First off, it's helping us figure out that the ecosystem that we built internally now has a standard to latch onto. We don't have to have custom APIs. We can leverage a standard interface that'll help us expose those data stores in a consistent data fashion through the FHIR spec. So that's a good thing. The second thing it's doing is just saying, well, how do we address things like data gaps? Because you have a lot of structured data, but even in the clinical space, we have a lot of unstructured data. Believe it or not, we still, in the payer space, we get faxes and we get image-based unstructured data that has valuable notes, doctor notes and things in text that we want to include as part of our patient API. So the question then is how do we manage that? How do we contain that in their first releases as either reference PDF files, or do we take it and we start to OCR it and take it from an image to a structured text? So that's the second way, right? But what we believe, we may not have all the gaps addressed in our first release, but we're going to discover new areas. But I think we're pretty confident that going out the door, we have the fairly good understanding of what we need to do to meet the compliance standards. But we also believe that that FHIR environment is going to change how we look at exposing our data. And I mentioned this earlier, is like the second stage is moving towards, hey, let's build out that CDR repository and leverage some of the newer technology that we have in-house, like big data technology. We use a tool called Cloudera. How can we take that and actually take advantage of that world and expose that in a different way than we've normally been thinking in this standard, relational data model world, right? And so I think that has technology implications, but it has all the things that will allow us to move to a different stage and building around that ecosystem that exposes that data through a standard called FHIR. So I think all that is really great stuff, and I think it's going to really help us move down to a different way of thinking than we've normally been thinking in the past.
Thanks, Greg. Amit?
Yeah, I completely agree with Greg. Data management is going to be the key engine, if you will, around this mandate, as well as anything to do with any exchange of data. Traditionally, what we had been since about 2014, we've been receiving data in a CCDA format. And so in our backend system, just how Greg explained the MDM, we kind of had something similar like that, very focused and built around that format. Well, now there is, a completely new format that we're talking about, which is FHIR. And so how do we switch that into the FHIR format, and how and what can we do so that we can still get the data, the claims-related information, the clinical-related information in CCDA? We need to combine all of this. The CCDA coming in from providers' offices, the claims-related information that the payer has, combine all of this and then make it available. So it begs another question: is make it available using the FHIR APIs, which is where Greg was alluding to, is the standard format, right? We don't want to create a new format that makes it difficult for us to interact with other entities. We want to try to leverage as much as possible what is the national standard, and that's how everybody is going to be talking to each other. So in doing that, the challenge we faced was, okay, should we have a facade in the forefront, which used for converting the data into FHIR and this exchanging, or should we have a repository that can be helpful for faster and better performance? And we've kind of gone a lot of back and forth on it. Finally, we settled on the FHIR repository solution, as we got some feedback from other industry experts and those who've kind of been playing in this space for some time, like CMS and others. It was a true learning experience. But all these are very essential, because this is not just a one-time thing. You have to look at it as an overall strategy. And if you want to make that strategy come available for a lot of other scenarios, this has to be thought through properly.
Yeah, that's true. It's a journey. Jeff?
Yeah. And just one other thought, and I've cheated and read some of the questions that people had sent in. So I think the questions are asking about, what about vendor systems and mapping of those to these standards? Are there any regulatory requirements around that? And so I would say 95% no to that answer. NCQA is starting to say we're going to introduce FHIR standards for HEDIS, for instance, and but it's going to be for a small percentage. Maybe 1-2 HEDIS measures, maybe 1-2 exchange mechanisms. I think it's up to payers to really drive this strategy from the top. And I can see a world 5 years from now that unless you have FHIR interfaces as a vendor, you'd be out of business. From what I'm seeing, as Greg and Mitt talk about it, I'm hearing others talk about it as this strategic initiative. Unless you support FHIR interfaces in your applications, you won't be able to play in this healthcare world that's coming up. It's kind of like the banking example that Amit gave of being able to exchange checks. If you can't exchange checks in banking, you're not going to be in business. And so as payers establish their strategies for their data, they also have to be talking to their partners, whether it's the vendors, the providers, even other groups that make up CINs, ACOs, and really mapping out that strategy, not just internally, but externally. And we're starting to see those conversations. They're very much in their infancy as payers start to create just compliance with the CMS measure. And that gets to it's not an all or nothing thing. It's not a yes, no question. It's a matter of degrees. So implementing FHIR and making it a core of what you're doing doesn't mean everything is now FHIR and everybody has to comply with FHIR. It's the infrastructure that these guys were talking about. Hey, we ingest CCDAs from a number of vendors. That can still happen, and you can ingest FHIR at the same time. But going forward, it's got to be that strategic conversation, and this is just the first step in a journey, is what we're saying.
Yeah. So, there's one question that there's a multitude of third-party apps that are managing onboarding, validating security of the app, et cetera. Is there any centralized app that's out there credentialed that payers can hook into? Anyone familiar on that one?
No, this is Greg. I'm not I'm not familiar with any centralized credentialing tool, although I know of a couple of efforts going on in that area, but I don't know of any production-oriented one yet.
Yeah, I agree with that. There is some work going on in this space, and there are certain entities that are trying to come up with credentialing or endpoint directories or what have you in improving this exchange. But again, this is all new to everybody, so nothing is kind of ready in production.
Right.
Yeah. All right. There's one question here. What are your thoughts on the payer's lack of maintaining legacy IT systems or modernization planning, how that contributes to our current state? We are all grappled with that. Reluctance to update systems based on old technical language. Thoughts there?
I can provide some thoughts, and then maybe Greg can add on. That's a very, very valid question. And, a perfect example is, as Greg was talking about data management, they approached MDM a few years ago. That was their strategy, which really is coming into play right now. And that's very critical for a lot of organizations. They may have legacy way of managing data that may become really a hindrance right now, and able to meet the mandate or what have you. So they have to look at other options and vendor solutions, unfortunately, if that is the case, or start from scratch in trying to reorganize the data or what have you. So there are a lot of different challenges that can come across when there is different legacy applications. Fortunately, I would say for us, we've kind of had always an innovative arm in IT where we're always looking ahead. And so we had a lot of our data structure very well designed, keeping in mind for situations like this where we can easily access information and make it available. So, but yes, for those entities that have legacy applications, they'll have to look at and explore several different options.
Yeah, and I agree with that statement. The balance there is, if you're fortunate enough as a payer to be able to extract that data and move it into a more modern, for lack of a better name, we'll call it a data warehouse. Like we've had that in place for quite some time. It helps tremendously because you're not locked into those older integration points and data points, and those go back as far as IMS, and that's an older system too. So you can see some really older data. But if you don't have the ability to put in a place to contain that data off the mainframe in a more modern approach using a master data management plan, then you're stuck with this concept of I have the data in my mainframe. Do I have enough technical funding to wrap that information such that I can expose it in a FHIR mode? And that's going to be the challenge. And my only suggestion there is, is there a potential vendor or a third-party vendor, or maybe even if it's a case of IBM mainframe, someone you can partner with that would help expose that data at a much lower cost point than investing in a data warehouse or some other solution. There's lower cost solutions that are out there too. I mentioned them, big data solutions that are relatively inexpensive. They're not as robust as a formal data warehouse in traditional. We use Teradata. But there are options that you can use that are not high cost items that you can leverage to get the data out of the mainframe and into a lower cost price point using I would say I would start with a big data solution or a Hadoop solution and start with that.
Thanks. Here's a question related to patient data. As stated, so far clinical data is using, I'll spell it LOINC or SNOMED code systems, while financial data will be recorded in ICD or CPT, where the granularity will be missing. So if patient can receive data from provider and payer both, then how we're going to make sure that both are in sync? Amit, I see your head going up and down.
Yeah, no, that's a very, very good question. And this is one of the challenges that, we as payers are kind of dealing with. And very fair that, we have information coming from many different sources. Before we are ready to present it, back to the third-party app, we need to do some, what I call it in layman's term is deduping, right? And ensuring we are kind of providing the right kind of data, the integrity of the data is good and everything else. So again, this goes back to the earlier question in having the right data management solution in the back end that can help do all of that stuff. And if you don't have that, then that's where a lot of the entities may have to invest, and kind of do something like that. And to some of the examples that Greg was saying earlier, if you don't have anything, it can become a fairly expensive, mandate because of installing all the things that you're not having in place. But if you have the right data management structure where your ability to manage the different sources of data and ensuring that you're taking care of the duplicates and everything else, then you can fairly come up with the solution in a much faster fashion.
Thanks, Amit.
I'm going to jump in just a little bit here, if you don't. I just want to add one thing that may help the individual questioner. One of the things that I know the Karen Foundation is trying to do and has been a very big part of even the Da Vinci projects and things is trying to take that disparity between LOINC and SNOMED and ICD CPT and going through a single mapping exercise. And that has been done, I know, from a representation of the Blue Cross Blue Shield Association, working with an individual, Linnell James, who's been our champion at the association level, is working through, here's the list of clinical fields that we see are overlapping clinical data, clinical formats, and how much of that maps to your existing financial world in support of claims processing. And so about 2 or 3 years ago, we've gone through some of that work. That has been picked up by some of the other activities around Karen and Da Vinci to move that forward. So there is work in trying to get that baseline data formatting. And obviously CCDA is part of that. But I just wanted to let you know that it's not like we haven't addressed that. There's been a lot of activity over the years quietly in the background in trying to get that mapping and those corresponding fields mapped together.
Thanks, Greg. Yes, Jeff.
Yeah, two cents real quick on this, and I'd look at this from the quality perspective, the clinical quality perspective, because I saw this on the provider side when Meaningful Use 2 came out. They actually built measures, some with SNOMED codes and some with ICD codes, and the providers then had to code both, and they were not coding both, even though they technically should have been one for clinical and one for financial purposes. And what it got down to was governance. And so the work that Greg's talking about is really necessary from a governance perspective, so everybody's speaking the same language of what is the definition of X. So a patient won't understand what a LOINC code is, what an ICD code is. They'll understand what a disease means or a procedure, a diagnosis at that level. And so rolling those up into governance and speaking the same language at that level, even if it's a little bit more rudimentary. So ICD is, very granular, SNOMED's very granular. That's helpful for providers providing care, but as you get to the members, they won't know what to do with that. And so that governance becomes incredibly important. So you can speak a language that people can understand.
Yeah, reminds me of the days of mapping claims data to EOBs and what makes sense. Here's a question. Is it true that the FHIR repository is great for interoperability use cases, but not for support of deep analytics or BI? Do you agree you need separate analytic data stores?
This is Greg. I'll take a quick shot at that. Fundamentally, if we think about object data stores and traditional relational data stores, and even in the case of like data warehouses, when you're doing that longitudinal view, that long, deep analytics BI, you always have to play the balance of what form the data is in, whether it's in a form that you can actually do the analytics on, and then the performance of how you're going to drive that. So I have a tendency to say that in some cases, you would not get the BI analytics out of some of the storage that you have tuned to a FHIR repository in the way that you would want. But you know what? That's most likely being fed by some backend systems anyway that are again being broken off, like our data warehouse breaks off, and they have, you know, cubes and different types of BI analytics that pull that same exact data out for analytics. So I sort of tend to agree with your approach that you're going to have room in your models and in your technology for the analytics data stores versus just everything's going to be in one data store and it's going to try to be all things to all individuals. It just won't work that way. At least that's my opinion.
Okay, let's move on. For other payers, this is a FTE resource question. For other payers who are not involved in actually creating implementation guides today, how many full-time FTEs do you suggest they budget for this work of IG creation? Thoughts on that?
You know, there is no magic number, to be very honest with you. It really depends on the size and the amount of data you are dealing with, and the number of members the organization has, and things like that. So there's variable factors that would go in, but the key is, you know, you definitely need the skill set on FHIR. You need the skill set for mapping. You need the right backend database. You need the skill set for understanding OAuth as a security measure and how patient matching is done, and all. So all these essential key skill sets are absolutely needed in order to make all of this possible. It could vary for a small organization, you know, for a few individuals versus for a bigger organization with a lot more members that they're catering to may require a bigger team. So it really depends.
You sound like a financial executive where always the question ends with it depends. Let's see, we have time, I think, for another question or so. Let's see. This one's for Amit, specifically from the questioner with respect to authenticating via app using auth flow. What type of matching are you proposing for the 15 parameters you mentioned around demographics? Deterministic matching or exact string matching?
Yeah, great question. We are proposing this. So the way we are doing this is, first of all, we are leveraging Da Vinci's implementation guide around patient matching, and what it calls out for specific fields. And we have a scoring mechanism that internally, when record or incoming record from, let's say, a third-party application is reaching out, those parameters that we are looking for matching, we kind of score based on every single aspect. So as long as all those 10, 15 fields are not 100% match, we don't consider that as a full match, which definitely sometimes can create issues because you may have not a lot of matches. It's still, from a security point of view, very essential to keep these things into consideration, and that's why we are going with the model of, you know, a full 100% score before we can start exchanging data.
Okay, thanks, Amit. Here's one where the questioner asked, other discussions they've attended have raised the question about whether it's legal to reject apps that don't meet a payer's idea of sufficient security and having all the privacy checks in place. Do any of you have any opinions about this? I know none of you are lawyers.
This is Greg. We actually had that discussion with our legal and compliance. We went through a whole round of discussions as to if we could provide a set of questions to a vendor who wants access to a member, and it would be a very simple scoring technique. We would not necessarily reject that vendor. I don't think we would have the right to do that. What we would do is we would make the member aware of that risk score and the things that the vendor themselves have ranked themselves on some of those items. I don't think we could actually you know, do our own internal penetration tests or anything against that vendor. However, there's certain things that I think we do today. And here's one. Here's a if you have an app and it's up in the app stores, if it's up in Apple, right? Apple is going to have a set of standard securities. At least we know that those apps are virus free, right? I would clearly say to our membership, hey, this is not an application that's been put up in any of the Play stores or Apple stores. You run the risk of actually having a potential security issue in that even the simplest security that is being done by the vendors, Apple and whether it's Google or whatever, has not even run any virus checks on this. And so it's up to the member to take the risk, but we could not, I don't think we would be in a position to deny access to the member having their data up to that member if the member so chose it. At that point, I think it would be the member taking the risk on.
Thanks, Greg.
Yeah. Greg, a similar approach we are taking as well.
Here's one. What's your view on consent management while sharing patient data?
So the data belongs to the member, and they have the rights to view it or not to view it. And we as a payer have to ensure that we are handing the data in the right hands. So consent is the most critical aspect in this mechanism. And if a member, for example, if they're coming through this third-party app, we are treating this ability for them to register in the app and them coming through that app to us as a payer is essentially a way of consent. But then there are other organizations that have other mechanisms to basically do consent. So it really depends from organization to organization on how consent management is done. But it is absolutely at the forefront and the core of maintaining the security of the data and ensuring that the privacy is maintained for the individuals.
Yeah, certainly a big discussion point for enterprise risk management. Here's a curious question. What are your thoughts of using either the Homeland Security TSA method or banking industry methodology of person identity? Any thoughts on that?
There are a lot of work groups that have been in place across healthcare industry trying to solve for this. And a lot of these approaches have been visited. Keeping in mind the best approach and what would work the best, I think that kind of varies. But there are some standards that are being put together by Karen, by FAST, ONC's FAST. So that's really creating the, I would say, level plane on how everybody utilizes security in a same fashion.
Well, thanks, Amit. I see the hour is just about up. At this point, I want to say thank you to each of our panelists and also to everyone in the audience. You've sent in many, many questions. Unfortunately, we did not get to all of them, but it's been a great session. You all bring great experience and thoughts. And thank you again to HL7 and to Sidious Tech. Jeff, I think you're certainly a resource. You can be out there for any of the participants in the meeting if people have additional questions. And with that, I will say thank you. Have a great day, everyone. Thanks for joining.
Thank you.
Thank you.
Thank you. Thanks a lot.